rather than acute kidney injury. Though, of course, we need to speak about all of them, but of course, I'll speak about highlights, not about everything. Details you may read. Now, look, chronic kidney disease or chronic renal failure initially it was called. A lot of people are going to hemodialysis. This you know, this is important. Because of such kind of question like CKD classification or based on, I don't remember now how it's written. We may open based on either GFR or if you see classification of CKD. I don't know if we are speaking about CKD classification. It is based clinical stages. Stages of clinical manifestation. Stages are based on this. GFR. How to calculate GFR we have already spoken. Next. So I'm not staying too long on this. But it's important. Kidney damage with normal or preserved, a bit increased even, maybe compensatory increased GFR. Absolute GFR, 125. Yes. Ideal, let's say, GFR, optimal. But what's the difference? I want to show you one thing because this in my lecture should be, but for saving time, I have shown you during the lectures. GFR, CKD, stages, images. For example, this one, this element. Is it? Look, what is written here? What is written here? Stage 1, kidney damage with normal kidney function, 90 or higher. But kidney is damaged. Otherwise, if only GFR will take it, means that all of us have first stage. Yes. Because GFR, kidney damage with GFR, either maybe with normal, yes, but above 90. Stage 2, kidney damage with mild loss of kidney function. Here is showing how much percent of kidney function is lost. This is GFR, don't get confused. Okay? Stage 3, mild to moderate loss of kidney function. Moderate to severe loss of kidney function. They are corresponding. Because GFR is showing what? Kidney function. Stage 4, severe loss of kidney function. This is called either kidney failure or end-stage renal disease or end-stage kidney failure. All are synonyms. Here, by the way, is used the term kidney failure. In prior versions, it was written as end-stage renal failure, but it's the same. Because nowadays, instead of chronic renal failure, we prefer the term CKD. But for 5th stage, the renal failure, because it's pure renal failure. Okay, you may take a photo of this if you don't have. Just let me increase the size.
It's fine,
so
you can.
It's a file. It's not.
Yes, it's
No, it's fine. You can scroll because video is on.
That's all. How about this? Just to show you the importance, if it will appear, of course. It appeared. End stage. Here is showing causes. Look, diabetes, blood pressure in various groups, ethnic groups, white, black, Asian, American, Indians, and so on. Anyway, mostly you see diabetes and blood pressure. If you remember, we had similar slides that in recent years. Look, paradoxically, two main causes of chronic kidney disease are extrarenal: diabetes mellitus and arterial hypertension. For both of them, kidneys are targeted. Chronic kidney disease. Look, many terms are used to describe states of GFR, not require renal replacement therapy, chronic renal insufficiency, renal failure, renal insufficiency, pre-dialysis, pre-uremia. Uremia. Uremia is an advanced stage of CKD when creatinine is becoming too high. And usually this is either close or is already candidate for hemodialysis or RRT. They are imprecise and poorly defined, yes. Measurement, we have annually made, creatinine clearance, estimation. Now this we perform GFR calculation, mostly. More than 10 formula for estimation of GFR. We have spoken MDRD most widely accepted. Now it's an old lecture. Nowadays CKD-AP is more accepted. MDRD in comparison with Cockcroft goals. Risk factors, look, diabetes mellitus, hypertension, they are already risk factors. Autoimmune disease is age and race because you remember that with the aging, GFR declines. Metabolic syndrome, you need to tell why, because it includes both arterial hypertension and diabetes mellitus. Family history, CKD, infections, autoimmune diseases, nephrotoxic medications, non-steroids. We may have NSAID-induced kidney disease. Causes, look, diabetes is so common that we have diabetic and non-diabetic causes. Non-diabetic may be glomerular, post-infectious glomerulonephritis, tubular interstitial, vascular, cystic, remember this, autosomal dominant polycystic kidney disease. In this case, kidneys are enlarged. On palpation, we may palpate easily. If in your tests, I mean in future for FMGE, for USMLE and so on, you'll read that, for example, palpable mass, bilateral palpable mass in lumbar region, very often it is indicating polycystic kidney disease. What is polycystic kidney disease? Disease of unknown origin. We have also autosomal recessive form, but mostly autosomal dominant form. Just to have 1, 2, 3 cysts, it doesn't indicate polycystic kidney disease. If now all of us will undergo ultrasound examination of kidneys, in 3 or 4 of us we may find some cysts. This is called like revealing by chance. Themselves they are not problematic, they are not dangerous. But polycystic kidney disease sooner or later leads to hemodialysis and transplantation. As soon as I have seen, sooner or later they have become patients for RRT. It's a serious condition. Maybe CKD in transplantation. Transplanted kidney also may undergo these features. This slide, you remember? Similar slide I have shown there. In 1980 up to 2002. Okay? 30 years approximately. Yes? 1890, 90, no, 220. 22, I have a larger one. Okay, doesn't matter. Look, this is cystic kidney disease, polycystic kidney disease. It's on the same level, number of patients. It is shown that it's approximately on the same level. About Armenia or in your country, I don't have statistics, but similar. This is glomerulonephritis. But these two, this one is should be hypertension. And this is diabetes. It is with increasing. Taking into account, for example, particularly high level of metabolic syndrome, lifestyle, fast food. About this I told you. Yes.
For diabetes.
For diabetes and for metabolic syndrome. These are really important issues. Next, manifestations. Look, everything is impaired, all types of metabolism. Sodium water metabolism. As a result, we may have edema and circulating blood volume hypertension. Abnormal acid-base abnormalities, metabolic acidosis, metabolic acidosis. Now, one of the indications for hemodialysis is not only high level of creatinine. One of the indications is uncontrolled acidosis, hyperkalemia, maybe both. So not only creatinine level matters. It's how to say like byproduct, because very often we have these issues. Okay. Next, abnormal hematopoiesis. Why? Because we have anemia. If you open Davidson in anemia part, you may find, because it's too large chapter, I don't want everything, but remember that there is a term, anemia of chronic disease. One of the best variants is anemia in CKD, because a lot of chronic diseases may be associated with anemia. One of the classical examples is anemia seen in CKD due to lack of erythropoietin. And how is it related to the kidney? Because it is produced by which cells? Homework. Cells which are producing erythropoietin. Which cells produce erythropoietin? Of course, in kidney, which cells? How is the name? Erythropoietin producing cells or? Metabolic acidosis due to uremia or RTA. What is RTA? Renal tubular acidosis, because acid-base balance also is being regulated by these hormones. And this also may be indication for hemodialysis. This is also, uncontrolled. Cardiovascular abnormalities, hypertrophy, coronary artery disease, diastolic dysfunction due to left ventricular hypertrophy, because hypertrophied heart relaxes more. Relaxation is more impaired because systolic function is more. Abnormal calcium phosphorus metabolism. Why? Because of calcitriol. Vitamin D is also reduced by, and also problems with parathyroid gland and everything regarding to this. As a result, we have hyperphosphatemia, pruritus, and arthralgias, hyperparathyroidism, compulsively, and renal osteodystrophy, up to stone formation and so on. This is CKD management. Look. It's not in your kit, it's but anyway. This is, look, GFR 100, 75, 50, 10, 0. Look, below 50 is kidney failure. This is the time in years, follow 4, 7, 9, 11 years. So patients without treatment, you see, you don't see. Direct decline. Yes. In average, in a few years, they are dying. If patients have received early treatment, look, it's 4 more years in average. If they are just now receiving treatment, I thought, because very often they are going to seek for, because it's asymptomatic for a long time, still we have improvement in average 2 years. So this is important. Look, they are reaching to this kidney failure end stage in this period. 7 years, and it is, of course, in general. Look, what should be treated? Diagnostic workup to decide underlying etiology. Though, why is it important? For example, if it is, arterial hypertension to control hypertension. Yes. Though even if it's the hypertension, but we have increased blood pressure, we should control. Secondary. If it's polycystic kidney disease, not always, sometimes possible surgical resection. But of course, if it's discrete, usually it is diffuse and we need transplantation. Treatment of hypertension, dyslipidemia, that's risk factors. Treatment of anemia, treatment of hyperphosphatemia, avoidance of dehydration, nephrotoxic agents, because more is the patient dehydrated, higher is the level of creatinine, potassium, hyperkalemia. Proper dosing of drugs, taking into account pharmacodynamics, pharmacokinetics, and because remember that most of the medications are excreted by the kidneys. And preparation for renal replacement therapy. This is for urine. Evaluation, serum electrolytes, urine spot protein analysis, 24 hours no longer recommended, but usually we are collecting it once. Look, we are collecting 24 hours, but giving one portion. This is for 24 hours proteinuria. How to understand? Of course, if in, I don't know, 100 milliliters is this much, you can calculate in 1 liter how much and how 24 hours. Antinuclear antibodies, C3, C4, SPEP, UPA, these are seroprotein and uniprotein electrophoresis. So subtypes, globulin, albumin, microglobulin, and so on. Kidney ultrasound, urine sediment analysis, again for this. Biopsy. Biopsy may show us, for example, it is nephrotic syndrome. If it is nephrotic, which type of glomerulonephritis? Minimal changes of disease, or already a level of glomerulosclerosis, or renal amyloidosis, or multiple myeloma. We have multiple myeloma.
Yes.
I have sent you.
Yes.
I have sent you.
PPT, yes,
It's enough. Even PPT is enough, I mean, for multiple myeloma. Taking into account that you are third year students, in fifth year you will pass hematology, you will pass nephrology. This much is enough. Treatment of hypertension, I don't want to speak about this. Anemia. This is very important, anemia treatment, because look, anemia decreases the quality of life. They are very weak. They are unable to do anything. Not only in this condition, when they have anemia. Any anemic person, if it's severe, of course. Look, one of my relatives, like say aunt-in-law, a few years ago appeared that she had lung cancer, subtype I don't remember now, in Spain. They are living there. They skipped for a long time, all the time she had cough, she went, they performed X-ray not always is showing, should be done CT. Auscultation, nothing. And after a few months, they decided to, after half year or maybe more, to 1 year, they decided to do CT, turned out that very huge cancer. Fortunately, it is responding to this is not chemotherapy, it is it's peroral chemotherapy, let's say, tablets. And on this medication, cancer disappeared, but S2, yes, it was sensitive variant. Absolutely no signs of cancer, so disappeared. But has to get this medication daily, 4 tablets. And now the name I tell you. It's called Alecensa. It's trademark. Anyway, it's chemotherapeutic medication, peroral. Very effective if it is for selected patients. But it has side effect. It is causing anemia. Now she's feeling very bad, not now, long years, due to this anemia. Even sometimes she's skipping this medication, hemoglobin increases, she's feeling very well, but the risk of recurrence is very high.
Yes.
So look, unpleasant issue. Again, anemia of chronic disease. Chronic in this case is oncology. So, diagnosis of exclusion. So you should find out, maybe we have some bleeding sites.
Yes.
In which case we have anemia. Anemia, either it's not normally produced, RBC, hemoglobin, or is lost. And remember, when we speak about anemia, we speak about hemoglobin level, not RBCs. Yes, RBCs carry hemoglobin, but anyway. Mostly apparent on last stages, stage 4, stage 5, due to decrease in erythropoietin production in the kidney. EPO stands for erythropoietin. Now look, this is unadjusted prevalence. This is hemoglobin up below 11 or below 13. Look, these dash lines are below 13. If GFR is becoming less, look, less than 15. Both are possible, but increases, of course. So less is the GFR, higher is the prevalence of anemia. Erythropoietin we are giving to target Hemoglobin levels should be between 11 and 13, not to be above, because high levels, there was a study, it's called CHOIR, has been established that very high levels above 13 are associated with higher mortality. In my opinion, because we cannot cheat on organisms too long, I mean, it's the synthetic erythropoietins we are giving, it should reach to some level, some anemia should stay, or should be in balance, like not too much. And also sufficient iron medication should be administered to create iron stores. Treatment of hyperphosphatemia, it's already due to decreased excretion in urine. It is also important how we can give. We can use phosphorus binders, especially calcium, lanthanum, renagel. They are binding phosphorus and decreasing the level in the blood. Bone and mineral disease, the hyperparathyroidism. Avoidance of dehydration and nephrotoxic agents. Nephrotoxic agents, first of all, are contrast agents. I'm sorry, I'll just make one call. Avoid exposure to radio contrast agents. Why? Contrast agents mostly contain what? Iodine. And which is nephrotoxic? So one should be very, very attentive. Why? Being attentive means you know what? Optimal ratio of risk and benefit. Now, I'm sorry, Paolo. In front of you, any symptoms, under any circumstances, should be the following: optimal ratio, risk and benefit. For example, you have a patient with STEMI, acceleration or myocardial infarction. You know that the best option is PCI. Patient is 50 years old, has no comorbidities, or I don't know, is hypertension or obesity and so on. If he will not perform, may die or may become an invalid, may have heart failure, may step 2 steps and have dyspnea, for example, have edema. So early PCI prevents these scenarios, or at least too much decreases the risks. Now, to do or not to do? To do. But taking into account that we are using contrast agents, which may lead to nephrotoxic effects. Even sometimes we need, it is causing acute kidney injury and we need hemodialysis. Okay? Okay. But 85 years old man, non-STEMI, has already borderline creatinine level. GFR is already decreased. You should either inform them, maybe they will insist, but the age of 85 to become a hemodialysis patient, quality of life, expected duration of life, which is also called lifespan, is less. Why? To make a person to suffer. Or you may suggest, it depends upon the jurisdiction of the country you are working, and maybe the state you are working. You know, in the US, from state to state, there are different laws. But you have to inform consent why you are taking for this. Okay? Dehydration. Dehydration plays a great role. For example, in hot weather, you may get creatinine level borderline. Patients may be dehydrated. You are asking them to repeat the analysis after a few days after taking enough fluids. One of the options, by the way, how to avoid contrast agents nephrotoxicity is proper rehydration. Before performing, of course, we are not speaking about acute conditions like STEMI. In this case, also we are giving IV fluids. But maybe, for example, patient with pulmonary pneumonia that is contraindicated, we are giving fluid, IV, rehydrating. And remember this right here. ACC, acetylcysteine. It is mucolytic agent. It is mucolytic acetylcysteine. These amino acids insert into the mucus structures and are cutting these molecules of sputum. And sputum is becoming more dischargeable. It is mucolytic agent, acetylcysteine. But nowadays it has been shown that it has also other effects. It has antifibrotic effect in interstitial pulmonary diseases. We are giving in very high doses. For example, One tablet is usually 200 milligrams. We are giving 3 times a day, or 600 milligram tablets also once a day. But also it can prevent these toxic effects on kidneys, nephrotoxicity. I'm not sure nowadays it is in the guidelines, but there are such kind of publications, and we are giving high dose of statin, not high, atorvastatin we are giving before the day, 1 day before, and on the day of the scheduled procedure, and 600 milligrams of acetylcysteine. These molecules are combining, are competing with molecules of iodine maybe, and by this they are making less effects on the kidneys. To tell that it is working in 100%, no. Some transient increase after procedures we see, but not always. These patients are becoming hemodialysis patients, or they have acute kidney injury, though we may have acute kidney injury. It's called contrast-induced nephropathy. Remember this term, even in the subtypes, CIN1, 2. Contrast-induced nephropathy. Okay? Proper dosing of drugs, dose reduction or interval extension, taking to give time for excretion. Preparation for renal replacement therapy. Already a bit we have spoken. It is fistula formation, special dual lumen catheter, and so on. Indications. Let's speak about this because such kind of questions you may have. Absolute indication for RRT. Uncontrolled hyperkalemia and acidosis. Uncontrolled hypervolemia. On this background we may have pulmonary edema. If we have pericarditis, by the way, it's uremic pericarditis. By the way, we may have pericarditis in hemodialysis patients. It is due to these filters, secondary infections, and so on. It is procedure-related complication. Altered mental status and somnolence. It is already encephalopathy and bleeding diathesis. Diathesis here means predisposition. So, or hemorrhagic syndrome. So, easy bruising, let's say, hematomas, bleeding from any side. Indications relative, worsening kidney function. Look, GFR in diabetics, lethargic malaise, metabolic acidosis, nausea, vomiting, and poor nutrition. I mean, not only GFR decrease is an indication. Uncontrolled hyperkalemia, because patients very soon will die of hyperkalemia, which may lead to cardiac arrest or life-threatening repair, then cardiac arrest. Transplantation, immunosuppression is almost always a must, which means that we may have rejection if we don't do. Look, if it is focal segmental glomerulosclerosis, usually it is needed early transplantation. That's why we are performing biopsy. Increased risk for infection because we have immunosuppression, bone loss, cardiovascular disease. Contraindications, look, active use of illicit drugs, severe extrarenal disease, current infection, malignancy. Again, now I don't know their guidelines. Each year it is also updated. For example, in cardiology, if expected duration of life of a patient is less than 1 year, we never perform ICD or CRT implantation because these are expensive drug methods. And if you do it after 2 days, patient will die. Yes, sometimes they insist out of pocket they are paying anyway. One of my friends is very famous electrophysiologist, invasive heart told that he had 2 conditions, 2 cases. That patient had, if I'm not mistaken, like severe malignancy. They insisted on ICD or CRT, I don't remember now, implantation. One of them died very soon. One is a few years, is living still, is alive. Though he had informed about the possible complications. So, expected duration of life. Expected life duration for lifespan. We are taking into account. Summary is increasing in population. Early detection is needed. Early involvement of nephrologists in the care when GFR at least is less than 30. We should treat for manifestations and complications, and RRT, time referral for excess, and timely transplant workup. So these are details I don't want. This is a case you may read at home. A few things I'd like to explain. The black slide is not right. First of all, let's make a pause here. I think here we should have the lecture of urinary system. I'll not keep you too long here. I understand you have other exams, different groups. We don't have here downloads. Okay, we look here in Gmail. Nephrotics, CK, pyelonephritis. Kidney infection. No. Urinary system. Let's speak why this CKD. Now we'll do like this. A bit we'll speak about CKD, a bit about acute kidney injury, pyelonephritis, then you may go. Because if I speak about multiple myeloma, one issue I'll tell you now for multiple myeloma, which are main highlights, I'll tell you. Okay. Now look. I don't need these. At the end. Why CKD is a progressive disease? I told you the mechanism. But here you may find a lot of interesting issues. I told you that here we have like this.
Yes.
In 24 years, similar to that one. Is diabetes and hypertension as leading causes of kidney failure. Incident end-stage renal disease rates by primary diagnosis adjusted for age, gender, and race. It is 2007. That one was a bit earlier. Statistics. This is US statistics, of course, but I don't think that in other countries it's somehow. This is polycystic kidney disease. Look. Make for operation. Mess. Look. See. Typically, polycystic kidneys weigh 20 times more than their standard weight. That's why they are becoming palpably large. Now let's speak about this. It is about the treatment, but not only. Now look, why disease is progressive? Because we have nephrons. First of all, disease is becoming CKD becomes apparent when usually more than 50, more exactly 70% of nephrons are dead. Each kidney contains 1 million nephrons. Why is it progressive? Because inherently the initial cause. Remaining nephrons are undergoing hyperfiltration, it's one of the factors, and thus die. Undergoing sclerosis. Sclerosis means death. But what is causing this sclerosis? One of the factors is increased intraglomerular pressure. Now let me show you some things. Now we have effective filtration pressure. It will not allow us because it is PDF. Just a minute, we'll write here. We have filtration pressure, yes? Or effective or net effective filtration pressure, which was equal to hydrostatic pressure minus P oncotic plus P intraglomerular or intracapsular. This is clear. It is corresponding to blood
Blood
pressure
pressure.
in that part, of course, not. Oncotic, it is due to
Protein.
altitude usually. Remains intracellular pressure. It is pressure inside the boneless capsule or intracapsular. Pressure is mainly formed due to the difference between vas afferens and vas efferens pressures. Now, remember this and maybe to this side. No. Now look, this is afferent arteriole, this is efferent arteriole. Here, we have angiotensin 2 receptors. Angiotensin 2, while binding with these receptors, it makes vasoconstriction, which is needed for filtration. But this is increasing intraglomerular pressure. Accordingly, if it's above some value, it is killing the kidney nephrons. That's why ACE inhibitors and angiotensin 2 receptor blockers are nephroprotectors. They are dilating different arterioles. Yes, as a result, GFR decreases. But there are a lot of issues. First of all, yes, GFR decreases. But let's imagine we have renal artery stenosis, especially bilateral. So the only way of filtration pressure is intraglomerular pressure. Hydrostatic pressure always is less. Oncotic more or less is stable, so what is remaining? Intraglomerular pressure. So if this intraglomerular pressure will remove, we'll have no filtration and patient will die of acute kidney injury. Creatinine will rise, potassium will rise, and so on. So that's why it's how to say, by having two blades of razor. Like from one hand, they are number one nephroprotectors, but from another hand, if you'll not be attentive, it may kill the patient. Depends what. That's why, if it is unilateral renal artery stenosis, one side, it is relative contraindication. If it is bilateral, it is absolute contraindication. Okay? It is particular case. But when to give ACE inhibitors and when not to give in patients with renal diseases. Approach is this. If patient, remember first of all, main first danger is hyperkalemia. And patients with CKD already have hyperkalemia very often. On early stages it's hypokalemia, then it's becoming hyperkalemia. So if we prescribe ACE inhibitors, patient may die of hyperkalemia. By the way, be attentive. If patient is on hemodialysis, you may give anything you want. Because during the procedure, these extra levels will be removed. So we easily give our needed medications. But before this, you should be very attentive. Now, hyperkalemia, yes? If creatinine is not too high, up to 200, we may give with a caution. If it's very high, 400-600 microgram, we are not giving at all, because the risk of hyperkalemia increases. In borderline cases, we are giving, and the protocol says that you may give as follow up if within 2 weeks or 10 days your patient's potassium levels are not increasing, you are moving on. GFR is not decreasing too much. If yes, either you should adjust dose or remove medication. So this is nephroprotective role of these medications. By the way, calcium channel blockers also are decreasing, but not that much, the pressure. They are metabolically inert. They are not acting on electrolyte balance. They are not acting on lipid balance. For example, beta blockers may contribute to atherosclerosis, and so on. Okay? Was it clear?
Yes.
Pyelonephritis, a bit, let's speak about this. To be honest, this lecture about acute kidney injury I don't like. It's not the best. And there are a lot of misprintings. A few years ago I corrected most of them, but again still appear. because I found in web, I have not written, to be honest, for not having enough time. Kidney infection in SL is not your problem. This one, I think. Pyelonephritis.
Accept.
Just a minute. No, I know, but maybe. Okay, this one I have sent because two we should. Okay, let's start from this. This is bacterial inflammation, is UTI, bacterial infection of the kidneys. Let me close you, and you appear here, and you are coming here. You are like this. So bacterial infection of the renal pelvis, yes, pelvis means pillows, tubules of interstitial tissue of one or both kidneys. So we may have unilateral, bilateral, or pyelonephritis of a single kidney. Because maybe congenitally single, maybe surgically removed. In this case, you should keep this kidney, as we are telling in Armenia, like your eyes light. Because this is the only kidney. Compensatory. Okay. Potentially organ or life-threatening infection, which is characteristic, causes some scarring of the kidney, especially in chronic one. With each infection may lead to significant damage. Pathophysiology, look. Mainly it is Escherichia coli, the most common. Though not only. Why in females I have already explained. Anatomical, pregnancy, pH changes of the urine, enlarged uterus compresses host-acquired infections may be due to coliform and enterococcal infections. Hematogenous spread is rare. It is typically sepsis, for example. Frequently due to ureterovesical reflux, because usually without this I told you cannot have infection. These are causes. Coagulase, negative staphylococcus, Klebsiella, Pseudomonas, outpatient department, inpatient department, then you may compare. But bacterial infection. Complicated etiology, Escherichia, Klebsiella, Enterobacters, and so on. Dysuria, pyuria, so pus in the urine, in females, in children mostly. Escherichia coli, not also Escherichia coli, but maybe Staphylococcus. Saprophyticus in young sexually active patient, because I told during sexual contact it may come. That's why in females, due to anatomical circumstances. Less frequent are other community acquired infections. The Escherichia coli appears in all these cases, as you can see. This is catheter and maybe pyuria. Pathology, pyelonephritis. Kidneys are enlarged, inflammation. We may have interstitial infiltration of inflammatory cells. Okay. We may see abscess on the capsula and corticomedullary junction. It is called. Wait, there was a special term for this pus. Okay, I don't remember. Result in destruction of tubules, apostematos. Apostematos kidney, like this pus accumulation, results in destruction of tubules and the glomeruli. If when chronic, kidneys become scarred because we have nephrosclerosis, contracted and no function. As a result, pyelonephritis is one of the most common causes of. By the way, of the secondary hypertension is very common cause by the regulation of water and electrolyte balance. And second to CKD. Pathogenesis. Rectal and or vaginal reservoirs, I told you. Colonization of perianal area. Look. Urethra. Look how close it is to the rectal and vaginal infections. So infections easy, taking into account that it's shorter and larger, are passing. Bacterial migration to perivaginal area here. Look. It's ascending infection, remember, through urethra to bladder. And this myoepithelial layer is continuous, I told you.
Yes.
Intercourse may contribute to urethral colonization and ascending infection. I told you, one of the variants is called pyelonephritis in pregnancy.
Yes.
It's a particular kit. One I told during first sexual contact. It's called post-defloration pyelonephritis. Very common. So, bacterial infection in first trimester, which we are ascending this level, may cause also in late stages. In pregnancy, it's very common. By the way, it's very common also in diabetic patients who have immunosuppression. When I was working in a large hospital, endocrinology department was one floor above, and most of these patients had pyelonephritis. And I mean hospitalized diabetics, not just diabetes, outpatient. Remember signs and symptoms. The most important for acute pyelonephritis is fever with chills. Otherwise, just fever may be pneumonia. Fever is high grade. Flank pain, because capsule is involved. Yes, nausea, vomiting. Renal angle tenderness, it is costovertebral angle. Confusion in the elderly. By the way, in the elderly, it may appear as behavioral changes. You may see that your grandfather, for example, is not adequate in behavior, out of nowhere. Even they may have low-grade fever because they're atypical. Leukocytosis, by the way, in the urine we are searching for this WBC, pyuria, bacteriuria. So, additional symptoms of lower tract involvement. Dysuria and frequency. You remember in first lecture of urinary system I told dysuria is very typical for cystitis. Frequency also. They are going to the washroom very frequently in small portions. It is indicating inflammation. Mechanical risk factors. We have constitutional risk factors like diabetes, immunocompromised conditions, and structural abnormalities. Look. Vesicoureteral reflux, especially in young children, it is active and reflux is more. Calculi, it is more typical for chronic obstruction. Urinary tract catheterization, it's infection, ascending infection. Nephrostomy again. Nephrostomy, look, when one of the variants, for example, urinary bladder is removed due to bladder cancer, and we could not form a new one, neocyst formation, remember that term, neocyst. New cyst, neocyst formation from the intestines. Of course, it's not functioning as the normal because it doesn't have innervation. Anyway, you have to compress for it to be drained, emptied. But anyway, it's better than the second option if they cannot for some reason, so you don't have this help. Oh yes, it's performed nephrostomy. Here, no? Here. This is removed, yes? So this stoma is opened here, the catheter is inserted, and it is here you have collection decks. Unpleasant, but if you compare, the patient may not stay alive if urinary bladder cancer. By the way, urinary bladder cancer, first risk factor is smoking. Statistically, it is more commonly results in urinary bladder cancer rather than lung cancer. Pregnancy, I have already. Neurogenic bladder. If we have spinal cord damage, spina bifida, yes, congenital, multiple sclerosis, what? It is leading to impaired regulation of urination. And for ascending infection, it's very good. Prostate disease, benign prostate hyperplasia, remember this term, and prostate cancer. And not prostate cancer. Bladder tumors, look, urethral strictures. Sometimes these strictures may be so expressed that even this catheter experienced urologist may not insert. In this case, we perform cystostomy. Well, how is it done? With a tracker, with this device, we make a hole and entering inside the urinary bladder externally. Of course, it's not common, but possible. Diagnosis. It's not always straightforward. You may directly diagnose. Look, a number of studies which are used in chemical markers, have shown that many females who initially present with lower tract symptoms actually have pyelonephritis, but had cystitis first of all, urethritis. Extremes of age, presentation may be so atypical, feeding difficulty or fever, I told, behavioral changes. In the other, presentation may be mental status change or fever. I'll tell you more on fever, mental status change, fever, not only may result. So, laboratory diagnosis. 10 WPCs in the field of view, HPF stands for this field of view, is the usual upper limit of normal. Above this should be. Positive result on leukocyte esterase lipid test correlates well for detecting above. So either leukocytes you are detecting or leukocyte esterase activity. And esterase lipstick test is through express diagnostic method, which correlates well for detecting above this. Positive nitrate lipstick test. What is nitrate test? Nitrite. So bacteria convert nitrates to nitrites. So according to finding their concentration, it may speak about concentration. Because but we may have false negative results. It's not the most valuable. Urine culture insensitivity, of course, if patient has not received antibiotics yet, and blood culture. Because, for example, maybe up to sepsis. Yes. Radiological investigation. CT scan. Intravenous pyelogram, I'll show you now. Radionucleotide imaging with gallium citrate indium 111 labeled WBCs, so they appear in the urine. Intravenous pyelogram. How is it done? Intravenous pyelogram. If you remember, I think I have closed that one. Urinary system. Too bad. Maybe it's here.
No, closed.
No, that email is.
Closed.
You close, open another PPT from that.
Unfortunately. I need to show you one thing.
The first.
The same one, yes.
This is here. Let's download. Okay. For downloading, I should open here.
Downloaded.
Let's maybe find it. And here, while speaking about investigation methods, I have written about this. Imaging studies. IV urography. Pyelography is a particular key. Intravenous pyelography. Nothing proposed before. And bowel preparation. Why? Because if there will be food, will be gas, it will lead to low radiological window. Visualization will be worse. Bowel preparation means special laxatives, special solutions are given to clean the bowels. How is it done? We give a contrast agent, IV, intravenous pyelogram, which is passing through the kidneys. It is excreted by the kidneys. And on X-ray we may see. We can visualize this urinary tract. It's narrowing, it's passing, it's not passing. Okay? This way avoiding cystourethrogram is something different. It is usually very often done in children. We, through the urinary catheter, insert special contrast dye in the urinary bladder. Then we see urination and how it is becoming less. So it's not the same. One is IV contrast, another is like
direct
water, yes, imaging directly. Like it's not the same. Yes, barium swallow and IV. One is IV contrast, second. And look, IV urography, for example. Here you see, on the right side, pelvic region is seen, on the left side is not seen. It means we have obstruction of something, I don't know. Because only one image I have here. Okay? Why I opened this? Because here it was not that good. Now where it is. Where are you? So here we see bilateral vesico-ureteric reflux, but it's not that good. On the right left side, there is bilateral ureteral pelvic dilatation.
Mm-hmm.
You think it's pressure with blunting of forensis, where fornix is, yes? In the right kidney.
Mm.
Of course, quality is not that good, but for understanding what we can see in these cases. Bilateral reflux.
Ascent.
You see? Into the pelvic cell here. Systems of the kidney without dilatation of calyces or ureters. Not catheter, here is a catheter in the urinary bladder. It's not too much seen, just a minute.
Mm-hmm.
How to say, if your eye is becoming comfortable with this, it is coming with the experience. You may start to notice every detail. Starting from ECG, starting here. Dilatation. So here it's normal size. We don't have, but we have, we see that we have reflux. It is the AFC. First it is coming and going back. It's reflux. Backflow. Where are you? Well, though usually this is patient's right, but sometimes it's hit and right or left for us to distinguish. Managements we don't need, but what is given? Antibiotics. Problem. Look, because acute. Chronic or recurrent symptomless infection persisting for months or years, maybe like this. Another 6 weeks course if relapse, okay, this one for you. Chronic. It is repeated bouts of acute pyelonephritis, which may result in chronic pyelonephritis. So a lot of acute may become chronic. Clinical manifestations. We may have no symptoms unless acute exacerbation. What we may have? Fatigue, headache, appetite loss, polyuria, excessive thirst, weight loss. As you understand, symptoms are not specific.
Mm-hmm.
Progressive scarring may result in renal failure. What do we do? IVP gain, serum creatinine, blood urea, because it may result in renal failure. Culturing and sensitivity. Which complications we may see? As usual. Kidney stone formation, hypertension, secondary hypertension, and stage renal disease. Medical management according to CMS results of culturing and sensitivity. Drugs carefully titrated if renal function is impaired, taking into account also that gerontological considerations it is in the elderly very often. Nursing management, fluid balance, like how much they have taken perorally, how much IV, and how much is the diuresis. Fluids encouraged unless contraindicated for hourly temperature. For the hourly temperature checking, antibiotics, bed rest, teach to how to prevent recurrent infections, adequate fluids, emptying the bladder regularly, because if it is leaving, yes, you may become infected, and performing a recommended perineal hygiene, taking antibiotics as prescribed. Here should be common. I thought if we are not taking normal sampling of the urine, hygiene is not followed, we can get false bacteriuria. Treatment guidelines I don't want to speak about. You look, scar and contorted kidneys in chronic pyelonephritis. Strange. So glomerular sclerosis, I don't know. You see, these are teltulate, yellow, brown teltulate. Here are cases we don't have. This was the first lecture, and also here we had. Now we don't have. No. Yes.
Main.
Yes.
Here.
Take back once back.
Again we have to search glomerulonephritis. Again, for example, it is the same part. First I sent to me, I sent to you.
Right sector.
And this one, I'd like to speak a bit, it's continuation of pyelonephritis. When I'm telling that something we are going to finish early, never believe. 5 times it happened, if not more. I went to Dean, asked me, I finished 5 minutes early. Each 5 times I finished 10 minutes later. Please tell me, why are you asking? If material I am not finishing, I cannot. This is kidney. Kidney outer corpuscles glomeruli or Malpighian corpuscles. First he described, Italian scientist, normal renal tuberous, acute renal. I want to show you just some issue. Acute pyelonephritis, most severe and spectrum of UTI, acute bacterial inflammation, abscesses in cortex medulla, and polymorphs in tubules and glomeruli spared. Maybe cytomegalovirus, pyelonephritis, immunocompromised, but mainly it is bacterial infection. This is acute pyelonephritis loop. This is the pus. That one was the pus.
Slideshow.
Slideshow, but it's too much. I mean, okay, let's go. You want slideshow? Will be slideshow fun. You see? Leukocytic infiltration. Clinically, males less than 1 year, over 40 years. Females 1 to 40 years. This is what I told you. Fertile age, sudden onset tendency, post-operative angle. Temperature, rigors, cystitis, so frequency. Most resolve quickly, may recur, become chronic, and we may have complications. Pathogenesis. How? We may have pathogenous spread loop. It is rarely in sepsis in compromised patients. Bacterial adhesions, colonization, sending infection, cystitis. Vesical, ureteric reflux. Intrarenal one is from that last part of ureters, inside the helicis. Maybe congenital or acquired because of congenital defects of kidneys. Respiratory reflux, urine bacteria appear in the ureter. Intrarenal urine enters kidney peptide. Predisposing factors are the same about which we have spoken no need to tell. If no reflux, infection only in the bladder, though there was written that it's contributing factor. But usually without these refluxes we don't have pyelonephritis. Complication of acute pyelonephritis. Perinephric around abscess, pyelonephrosis, papillary necrosis, fibrous scars, and chronic pyelonephritis. All these are complications of acute. Chronic. Special for example. Chronic pyelonephritis has 2 types: reflux nephropathy and chronic obstructive pyelonephritis. Scars overlying distended cheilitis, chronic inflammation fibrosis, which involves tubulointerstitial part. Now look, reflux nephropathy is more common. Respiratory reflux pressure threshold, we have, this is organism, microorganism. Reflux in papillae upper, lower poles. And hypertension after 12 to 25 years. Chronic pyelonephritis reflux. It is anatomically, as you understand, weird dilation. Chronic pyelonephritis reflux time. This is the glandular part of the lysis. Scar. This is obstructive in older patients who have benign prostate hyperplasia, tumors, strictures, calculi, ureters, and of course in Asian patients. Clinical. Chronic renal failure we may have on the level. Hypertension. It is raining outside. Yes, it is raining outside. Look how good that you are inside. Not getting wet. Let's wait until it is finished. But if I'm not mistaken, up to 2 a.m. of tomorrow is given. The rain. It is in the center, in Avan, much more. So, UTI, but often negative urine cultures in this case. If you remember, there was written that in exacerbations they may become positive. Because already we have either reflux or obstruction. I mean, this is interstitial fibrosis, tubular atrophy, it's called thyroidization of tubules. It is reacting with special states I will explain. Thick arteries and maybe FSGS, focal, segmental, focal and segmental, sometimes it's called glomerulosclerosis. Accounts for up to of patients on dialysis, and we have other types of pyelonephritis too. Tuberculosis, xanthomatosis, pyelonephritis, non-bacterial inflammation of renal tubules. This is not for you. I mean, acute interstitial nephritis, not this year. In 5th year, you will pass
From nephrology.
nephrology. Now, this, okay, maybe now it will disappear.
Others. Last.
This one I don't need, let's close it. This one also I don't need. This one,
No need.
no need because it's open. About this, I may say to you, there is one more lecture I sent about acute kidney injury from my from okay? You may have 2 minutes rest. I don't know why it is not working if everything is okay. Functions of the kidney are taken a lot of things from this, you don't need. Look, creatinine level. No common pathological condition. Yes, I understand. Kate is more interested. Rather than renal disease, increases serum creatinine level. Serum creatinine does not increase until minimum 50% of renal function is lost. Creatinine clearance, imaging studies, a lot of things, complications, nephrotic. For nephrotic, I have sent the lecture. Acute renal failure. Acute renal failure is reversible, though we may have some remnant conditions. Clinical syndrome, where is sudden and pronounced loss of kidney function. It occurs from hours to days and results in kidneys fail to excrete nitrogenous waste products. Which variants we have? We have intrarenal, pre-renal, and post-renal. Post-renal is the most easiest. Urinary tract obstruction by calculi, tumors, clots, benign prostate hyperplasia, prostate cancer, which is tumor, and so on. Pre-renal is the most common, 60-70%. So here, exactly with the renal part, we don't have any problems. Well, volume depletion in hemorrhage, renal losses from diuretics, GI losses from vomiting, diarrhea, so dehydration, hypovolemia, hypoperfusion, maybe secondary to myocardial infarction. I was searching for this. What is this? Cardiogenic shock. Again, we have hypoperfusion. Dysrhythmias, cardiogenic shock. I mean, impaired cardiac output due to myocardial infarction. It is the same cardiogenic shock. They have written twice. Vasodilation in sepsis, anaphylaxis, antihypertensive medications. Look, the same AC inhibitors due to vasodilation will lead to this pre-renal variant. Intrarenal, look, we may have nephrotoxic agents, aminoglycosides, for example, gentamicin, which is ototoxic and nephrotoxic. Radiopaque contrast, heavy metals, mercury, solvents, benzol, phenol, non-steroids, ACE inhibitors. So ACE inhibitors can have direct injury effect through the vasodilation. And acute glomerulonephritis or acute pyelonephritis, yes, it's intrarenal or prolonged renal ischemia from myoglobin. For example, in burns, in rhabdomyolysis, in crush syndrome, which is already direct impairment of the nephros. Hemoglobinuria after transfusions and in hemolytic anemias. Pre-renal, we have spoken. Phases. Initiation occurs with the insult starts. Then we have oliguric phase, where urinary output, so dialysis less than 200 milliliters, potassium starts to rise, blood urea, nitrogen, creatinine are rising. And this is responding to fluid challenges. You are injecting IV fluids, you see oliguria. Then it starts recovery period. It's not recovery, the diuresis period. We see diuresis. is restored.
Mm-hmm.
Even we may have polyuric phase, more than normal. So there is a gradual increase in urinary output, beginning recovery of renal function gradually improves. Recovery may take 3 to 12 months, may have permanent reduction in functioning in up to 3% of cases. Key features, which are, by the way, you should remember that non-oliguria form also exists. With other phases are similar, but we don't have oliguria phase. But it's rare. Pre-renal, what we may see: hypotension, tachycardia, decreased cardiac output, decreased urinary output, lethargy, because of somnol, negative impact on CNS. Intrarenal and post-renal, oliguria or anuria. So, oliguria, anuria, you may see all conditions of acute renal failure. Hypertension, we may have tachycardia, shortness of breath, orthopnea. This is typical for what? Left ventricular heart failure. Acute left ventricular heart failure. Nausea, vomiting, generalized edema, anasarca, and waking, lethargy, confusion. So more or less symptoms are same with some differences. Just I'm not sure that it is absolute. Third, acute renal failure also may be used. Acute kidney injury is the same. Both are used interchangeably. Meanwhile, CKD is used instead of chronic renal failure. Laboratory profile. Look, elevated blood urea, nitrogen, and creatinine. Yes. Sodium retention, but may be deceptive due to water retention. Potassium increases, hyperkalemia. Phosphorus increases, calcium decreases. Specific gravity decrease and fixed. How it is called? Hypostenuria. I thought isostenuria, hypostenuria, hypostenuria. Age and age is what? Stands for what? No idea? What may be, for example, in your opinion? Until I'm responding. You know, it is, we have spoken about yesterday. Hemoglobin. Anemia, yes, we have spoken. And as a result, hematocrit. Maybe decreased. Okay? Because of RBCs, yes, mostly are responsible for hematocrit. Objectives: restore normal chemical balance and prevent complications until restoration of renal function. Trying to identify and treat underlying cause. For example, if it's cardiogenic shock, should become PCI causing this one, because most common cause is STEMI. Maintain fluid balance. Waste products, serial CVP readings, it's central venous pressure or jugular venous pressure readings, blood pressure strict, in and out. So how much is taken, how much has lost. May give mannitol, Lasix or endocrine. These are diuretics. Lasix is furosemide, Indian furosemide. Mainly temporary dialysis. But it's for this we'll use dual lumen disc catheter, will not perform fistula formation. If pre-renal fluid challenges and diuretics, to enhance renal blood flow, if pre-renal. Oliguria renal failure, low dose dopamine, dobutamine are used, for example, in cardiogenic shock. Dopamine has dosages. First dosage minimal is called renal dose. Just when we'll pass next year cardiology, remind me, I'll tell. Now, no need, because treatment is not enough. Calcium channel blood may be used to prevent influx of calcium into kidney cells, maintain cell integrity, increase GFR. And management, look, hyperkalemia, how it should be treated. The best option, of course, hemodialysis. But maybe used IV dextrose, insulin, and calcium. Calcium is contra potassium ion. IV, yes, it is shifty. IV dextrose, glucose with insulin, will help for potassium to come back inside the cells and away from the bloodstream. Cautious administration of any medication which can be nephrotoxic. Monitor arterial blood gauges and acid-base balance because it also may be medication hemodialysis, and monitor phosphate levels. KXLH orbital may need flex-rate seal. This is for usually again hyperkalemia. Azotemia, uremia are related to the rate of protein breakdown. So nutritional therapy is very important. Dietary proteins are individuals. Diabetes patients will need 1.5 gram per kilogram of weight daily. Fluid restriction is like this: urine volume plus 500 milliliters. Urine volume is 1 liter. Patient should take 1.5 liters. Role of nurse, because the nurses are doing a lot of processes to prevent infections, in care, support, because they are critically ill. We may have bed sores which may become lethal. Promote pulmonary function like prone positioning, pulmonary rehabilitation, reduce metabolic heat, motor fluid and electrolyte balance. Pathology is coming from renal failure and then stage renal failure. Stages are written is the same. You may read. Okay. By this, let's finish. But a few minutes for your questions and answers. First, as with group 301.
No. 3
On
Thursday, 21st.
About your unit consultation 303.
303.
If they will need consultation tomorrow, one of them has written, I don't remember which group. Just a minute, let me see, maybe what their students have written. It is for overall. If you need consultation tomorrow, because the day after tomorrow I have exam. Tomorrow you may come at 11 o'clock. On Thursday, I kindly ask you to come very early because I have second exam. From 9 o'clock, but okay, at 9:30 for everybody to be here. I'll try to start possibly early. And those of you who have fee issues, please solve this today, tomorrow, the day after tomorrow, but for the exam for the day after tomorrow, for Wednesday, for us to know who is coming, who is allowed, who is not. It is, we are wasting a lot of time. During the exam, your practical classes teacher, I think, will be present and will have also practical skills.
Yeah.
What is written?
Palpation.
What else to tell you? This is okay. This I don't need. This I don't need. This one I don't need. What else is left? One thing I remember. Thyroidization. Yes, was written. Thyroidization. This is where renal tubules are shrinking, and histologically, their appearance resembles thyroid gland. They are filled with gel-like protein, and you know that this, how it's called, colloid structures are typical for thyroid. Colloidal. It's called thyroidization of the tubules. In multiple myeloma. Okay. State. Okay, let it be this one. In multiple myeloma, this is oncohematological disease. Bone marrow overproduces problematic B cells, which overproduce immunoglobulins, especially light chains. Now, and this free light chains accumulation we may have various appearance. So if it is in proximal tubule, it is called Fanconi syndrome. This is crystallization within epithelial cells. Also, we may have light chain deposition. Afterwards, it may result in AL amyloidosis. It is in the glomerulus. If it is in distal
Distal.
part, it is called myeloma kidney
Kidney.
or cusp nephropathy. Cusps contain of protein, are proteins or made of proteins. How they are depositing. Now look, we have normal protein, horseful protein in urine. It's normal. But when these immunoglobulin light chains are bound with them, they are becoming too large and they cannot be excreted.
Deposit.
And they are depositing, and we may have deposition like AL amyloidosis, it's one of the variants, and Fanconi syndrome. Now look. Which immunoglobulin? Mostly it is an IgG, maybe IgA doesn't have, maybe IgD. Male to female ratio, just I want to show you. It is not here. This is important, which variants we may have. Fanconi syndrome. Amino acid urea, phosphatidylium glucoseurea, proximal second type, renal tubule acidosis. Proximal tubular injury due to light chain deposition tubular epithelium. Cusp nephropathy. We may have acute kidney injury with little or no proteinuria. This is light chains combined with some morsel protein precipitating in tubules. AL protein primary amyloidosis will have nephrotic syndrome, as you understand. Monoclonal immunoglobulin deposition disease, it's very similar. It was again amyloid. Hypercalcemia, it is causing thirst, polyuria, bony and abdominal pain, headache, body destruction from metastasis. We have something which we call, it is here, or next one. A lot of slides are the same here. Just remember that the most common problem is this one. The most common problem is nephrological problems. These patients are becoming hemodialysis and need RRT, and their survival is very low. Now look. IgG. And this deposition is called Benz protein, but it's not a diagnostic criteria nowadays. AL amyloidosis, maybe AH amyloidosis. In amyloidosis, by the way, we have AH, TTR. First letter, we have 26 to 34 like these variants. First letter always is A for amyloid, and second letter is precursor protein. Second letters, because maybe ATTR, transthyretin. AL, light chain of immunoglobulins. AH, hereditary. Okay? AA, serum amyloid A is protein, so precursor protein. Acute. We may have glomerulotubular interstitial variants. You'll see. This is so-called cracked symptoms, high calcium, renal problems, anemia and bone problems. For diagnosing, look, urine dipstick may be negative, express diagnostic. So we need protein electrophoresis. The word Bensch's protein, monoclonal globulin protein or immunoglobulin light chain found in the urine with molecular weight 22 to 24,000 kilodaltons or kilodaltons. Detection of Bensch's protein is suggested, but it's not a diagnostic criteria. Here are diagnostic criteria mostly. Yes, it is here. But only nowadays it's not considered the best option. Bensch's protein you may see in urinary system lecture in last part. Okay? Treatment you don't need, laboratory findings. They may have typical panda eyes due to hyperviscosity. It's bluish discoloration around the eyes, you may see. Okay, so this much I think is enough. Your combined highlighted lecture. You have any questions? So, if your group wants to come for consultation, other groups are when?
1st of June 301.
25th.
We'll have time. 25th is which day? Monday. You also may come tomorrow.
We have the tomorrow exam.
Okay, but look, on Thursday and Friday I have exams. When I should have your consultation? In case you need.
Saturday.
Or you may come after your exam. I'll be here on Wednesday. On Wednesday is your exam, yes? After the exam, come to consultation. It's not exam, it's consultation. You are asking questions. You need to logical. Non-logical why you are studying now, not during the semester. Okay. Stay in touch, something we may do, I don't know what, but something. Now you may go.